Okay, Sue.
Okay. Hello, everybody. Welcome to this webinar on PainChek, which will all be explained to you by our presenters. And I'm going to hand over in a minute to Jackie Poole, occupational therapy specialist in dementia care. And she will introduce Kreshnik and the actual webinar. Just want to say that there will be a chance at the end for questions, live questions, we hope. And also, if you want to put any questions in the chat, we'll try and pick those up. Don't use the chat for chat if possible, just for questions. And this session is being recorded and will be available afterwards on our YouTube channel. And so will the presentation, PDF of the presentation. So without further ado, over to you, Jackie. Thank you.
Thank you, Sue, and hello everybody, and welcome to this webinar. I'm very excited about listening to this one. I'm, as Sue said, an occupational therapist working in dementia care for many years and in lots of different settings, and have witnessed myself, and I'm sure many of you have as well, the impact of pain, and particularly unrecognised pain that's not then therefore getting treated, on people's cognitive abilities, their functional ability, their mental health, their relationship with others as well. So many different ways it has an impact. And, you know, we've been quite restricted in the way that we've been able to recognise pain. So to now have this new innovative technology to transform not just the clinical outcomes, but I think the everyday lived experience of dementia is really exciting. So I'm going to hand straight over to Professor, I'm doing it as well now, so Professor Kreshnik Hoti from PainChek, and he's going to lead us through this presentation. So as Sue said, put any questions you've got in the chat and I'll pick some of those out when we get to the end. And also hopefully we'll have some time for some individual discussion as well. Thank you. Over to you, Kreshnik.
Well, hi everyone. My name is Kreshnik and I'll be delivering this short webinar today on technology-enabled pain assessment and management in dementia care. Now, pain is such a huge issue, I'm sure you'll agree, but it's particularly a big issue in people living with dementia. And overall, I mean, pain is really changing in terms of prevalence, in terms of how we treat it, how we focus our treatments, and how we really deal with it in general. I mean, pain, as you know, is such a personal experience. It's affected by so many factors. Therefore, its treatment and management needs to take into account all of that. It was quite interesting for me to learn just recently. There was in the US, it was an NIH-funded study, which was published in JAMA a couple of weeks ago, about how basically pain
So I think we might have lost Kreshnik at the moment. Somebody else come off mute and yes, I think it's the screen's frozen, Kreshnik. I don't know if your Zoom's doing something peculiar.
I will just see if I can reach him through alternative means and see if his Wi-Fi has dropped out. Bear with me a second.
Thank you, Drew. The wonders of technology, hey? Sue, you're on mute.
Sorry, this hasn't happened before. And yes, I was just thinking of turning my camera off because I thought it was me, but perhaps it's not.
That's usually what we all do, isn't it? We imagine it must be us. Okay, well, while we're waiting for this to resolve, how about if everybody has a ponder about an experience they've had about supporting somebody where pain has been the issue, and be ready to share with us how you resolved it and what impact it had. So just to give us something to do while we're waiting would be great. Morgan, you've got your hand up.
Yes, hello. My name is Morgan. I'm in 4th year of pharmaceutical sciences. I'm actually working on a project with PainChek in Portugal. And what I've experienced last year was my mother was diagnosed with Creutzfeldt's, and it's a rapidly progressive type of dementia. And the experience I had is that there was a time point where my mother wouldn't communicate anymore, and the anxiousness, the angst that it gives you to try to interpret certain behaviors of this person that was my mother and was now some kind of child and then wouldn't speak at all, was such an angst, because you see that as such a vulnerable person and you don't know why she feels like that or why she behaves like that. And it was an aggressive behavior because I don't know if you know, but Creutzfeldt impacts also mobility. So she wouldn't have those type of aggressive behaviors that we can see in Alzheimer's, for example. But there was some changes in behavior, and not being able to actually pinpoint what was causing that type of behavior is quite a source of angst, because you want to protect that person because that person is so frail.
Yes. And it's even harder, isn't it? Of course it is, when it's your own family member. You know, I absolutely empathize, because my mum lived with dementia, and no matter how experienced you are in your own professional field, it's very different when it's a relative. Of course it is. Yes. I always think, I know you said she wouldn't do things, and I always think it's helpful to think she couldn't rather than she wouldn't, is quite useful. And it might just be a semantics of language, but in your case. But I think sometimes people do use the phrase, "Oh, she won't do this," or he won't do that, whereas actually it's that they can't, not that they won't. But I'm sure you appreciate that. But so do you think, Morgan, that pain was a part of that? Is that why you raised it at this moment?
Yes, because in the last weeks, she wouldn't speak at all, and we had to hospitalize her because she had a UTI. And what happened is that then she went into palliative care, and in discussions with nurses and everything, you saw that in pain management, in the morphine drops and everything, what they did, it was to look at her face and try to interpret, is she having pain? Does she look like she has frown eyes? Try to interpret those expressions, and it's the source of anxiety is quite, I don't know how to explain, but to see that person and see those changes in facial expressions or whatever, and not being able to know, and you want to know so much, that not being able to know how you can help is
Totally agree. So I think we've got PainChek back, and that is a really good moment to move us on, because of course we're moving on from the whole thing of having to guess to using technology. So Drew, back over to you.
My apologies. I think my internet dropped off. So it's exactly we're gonna tackle what Morgan was just saying, because it's such an important issue. So as I was saying, this NIH funded study is just confirming that increasing prevalence of pain. And as we know, people living with dementia also experience pain, and reasons for them experiencing pain are similar to everyone else's. Now, pain in people living with dementia is quite a challenge. Is more challenging. Pain is more challenging than in other population group, I would say. Up to 80% of people in aged care experience chronic pain. More than 70% of people in aged care actually have dementia. So you can imagine a significant number of people living with dementia in aged care do encounter pain, do experience pain. But the problem is that the pain in this population group often goes undetected and untreated or undertreated in some cases. And one of the key reasons is the loss of ability to communicate pain. Then we also know the pain is very subjective. There's other issues also that complicate this, such as lack of pain documentation. And it has been also recognized that inadequate education and training on how to identify pain is also an issue in aged care. So these are all issues that compound or the problem, or make pain identification and management therefore even more challenging. For example, when we communicate, when we have an ability to communicate, we often describe pain. So it's not that we only say, for example, that I'm in pain. We often describe that as throbbing, or I'm feeling uncomfortable, I have a burning sensation, stabbing, etc. People with dementia, often those with moderate to severe dementia, as you know, have lost the ability to do that. And this further complicates the issue of identifying pain. There are specific consequences to this, because basically this leads to poor management of pain overall. I'm going to focus on a couple of clinical issues that result in poorer management as a result of poor management of pain. And that is behaviors, so how pain affects behaviors, mobility and falls, as well as prescribing. When it comes to behaviors, for example, these are often signs that are manifested in people that actually having pain. So pain is the underlying cause of those behaviors. There can be nonverbal signs of pain, such as restlessness, or you have increased vocalizations and distress, etc. Sometimes people with dementia, as you know, experience aggression, social withdrawal. These are all very common issues, because over 90% of people living with dementia are affected by these behavioral symptoms that, as I said, are often caused by pain. What we also know by a recent study that was published in Australia, and that they actually used PainChek to identify pain. We know that in that study, and there was over 400 participants in the study, participants that had pain, so the pain group was 3.8 times more likely to experience behavioral symptoms. So the likelihood of experiencing these symptoms increases, but also what they found, as you can see from the slide here, that the severity of these symptoms increase. And there was even more distress to caregivers as well. We also know that these consequences lead to longer hospital stays for patients. About the studies that refer to about 18 days, increased risk of delirium, and obviously increased risk of antipsychotic prescribing as well. So high use of antipsychotic prescribing. Then the other issue that I wanted to focus was prescribing itself. So a person has challenging behaviors due to untreated pain. What we have in terms of prescribing implications is the antipsychotic inappropriate prescribing. Or a person with dementia becomes socially withdrawn or distressed due to pain. They are often diagnosed or treated for depression as well. So you have antidepressant prescribing associated with that. Or you have reduced mobility due to pain, which again is known to increase risk of falls and further injury, and that also then leads to either further injury or related prescribing. We actually have I don't know whether you remember this. This was back from 2009. This was a BBC article suggesting how wrong drugs are used for dementia, and this is referred to prescribing of antipsychotics. Actually, there was a Department of Health, UK Department of Health study that suggested that there are about 180,000 prescriptions of antipsychotics that are prescribed in the UK annually for people with dementia. And out of those, as you can see, nearly 80% or 140,000 are prescribed inappropriately. And as you would know, antipsychotics are associated with a number of side effects that do affect the quality of life of the person. And they're also associated with increased mortality rates. When it comes to mobility and falls, as I mentioned, there's an increased risk. So pain leads to decreased mobility, which then interferes with daily activities, and that then also increases the risk of falls. So these are clinical issues, clinical outcomes that are directly or indirectly sort of linked with pain. So the question then becomes, can technology help? Back in 2012, myself and two of my colleagues, Professor Jeff Hughes and our PhD student, Mustafa Ati, at Curtin University, we started a research project that would tackle this issue because I'm a consultant pharmacist, did a lot of medication reviews in nursing homes, and Jeff did that as well. What we saw was these PRN pain medications not being used, these antipsychotics being prescribed, but we saw a lack of pain assessments, and we saw a lack of pain identification. So that started our thinking of how can we improve this? Although there were pain assessment tools, they were using Abbey Pain Scale, etc. So this is how we started the question whether we can do something with technology that can help this. We came up with a PainChek concept. We did a few research studies to confirm the concept, to validate the tool, and then that got approved in terms of regulatory clearance from TGA, which is Australian Therapeutics Goods Administration. Then it got approval from in European Union and Canada and so on. So since 2017, started in Australia, this is a tool that is used in clinical practice. By now, it's been used in over 1,700 facilities around the world, with over 400 clients, a lot of contracted beds, as you can see. But more importantly, a lot of clinical pain assessments. So far, there's over 2.5 million pain assessments that have been conducted at point of care with PainChek. So what is PainChek? Basically, PainChek is a system that is comprised of a PainChek app, or the point of care pain assessment tool. Then it also has the digital analytics. It's a PainChek portal, and also has a very significant component, which we call the education component, and that we think that through that we also empower the actual users. So starting with the PainChek pain assessment part, or the pillar of PainChek. We know that basically, as Morgan mentioned earlier, assessing face for facial clues of pain is quite challenging, because what one person might think what is frowning or what is grimacing, another person might think that that's a natural face, especially if they know the person. So there's a lot of subjectivity, and as a result, inaccuracy in detecting pain as a result of that. And we know that face is a very important component to assess pain in people living with dementia, because facial changes in relation to pain, they're more intensive in people living with dementia. So PainChek uses artificial intelligence to identify 9 specific microfacial features that are indicative of pain. Then these features are combined with other non-facial features of pain, such as behaviors, voice, and so on. So there's a total of 6 domains. And these 6 domains are recommended by the American Geriatric Society, because pain in dementia is multidimensional. So in addition to face, you also need to assess other components. For example, other tools as well, such as PainAd or PainScale, as you would know, also have these other domains, and that is based on American Geriatric Society recommendations. And then when you assess a face, the pain indicators from face are automatically combined with non-facial indicators of pain, which the user goes through and assesses through a digital checklist, and that produces a final score. Now, a final PainChek score is no pain, mild pain, moderate pain, and severe pain, as you can see from the slide here. And this is how that relates also to PainScale. PainScale also has these no pain, mild pain, moderate and severe pain categories. This is in a nutshell the PainChek system. But now the question is, well, how this technology or this system reduces subjectivity when it comes to pain assessment. First of all, as Morgan mentioned before, I mean, when humans assess face in relation to pain, you got to look for things like looking tense, frowning, grimaces, looking frightened, as you can see here in PainScale. But that is done subjectively. That is dependent on whether you know the resident or not, and whether you think frowning or grimacing is actually frowning and grimacing. It's similar with PainAd. So PainChek removes this subjectivity totally by using AI. But then in terms of other components, in other scales, as you can see, when you assess vocalization, you still got to decide whether a vocalization is absent or present. And then within that, you have to decide whether it's mild, moderate, and severe. And that in itself has issues when it comes to accuracy. On the other side, PainChek, although this part does not use AI, it uses digital checklist, but we've taken advantage of technology, and we actually try to reduce the subjectivity by introducing a binary system. So the indicator is there or not. So you only have to answer yes or no. And then you also have the capability of pressing next to the information icon next to each of these features, and that'll tell you what that is in case, for example, a carer does not understand or has issues in interpreting the difference between, for example, groaning and moaning. So this is how then the tool further sort of reduces subjectivity. The second pillar, or the second key component of PainChek, is the digital analytics, or the portal itself. So what this does is basically documents pain. And we know that documentation of pain is an issue. Various studies have pinpointed to us before, as you can see these studies on the screen here, that not everyone has their pain documented. So there's a need to further document pain, or there's a need to improve documentation of pain. So the analytics part in connection with point of care solves this completely. The digital analytics then allows the users to compile various reports. So you log in and you can see, for example, how's your pain managed throughout the facility? What are your residents' pain levels in time, so chronologically? And more importantly, you can dig in further and see, for example, when they have pain, well, what sort of pain behaviors do they have? How is pain impacting them? And that way you can sort of take measures to better management of pain as well. Another recent, quite an important topic in scholars that in this area is how do we personalize pain management? This is very important, and the question is, well, can digital analytics help with that? Only recently, these are all February, March, sort of this year studies that this issue has come up as a very important issue. So the need to personalize pain management. In Age and Aging, which is one of the leading journals published by Oxford University Press, there's been a couple of recent studies highlighting the role of big data. How can big data potentially help with pain management as well? And one of the ways is that big data basically unlocks previously unrecognized patterns. in terms of when you assess the patient. So basically, this is clinically confirming what you suspected, what you clinically suspected, but it was difficult to prove before. So you're getting these patterns that emerge from big data that you can now see. And then the other question is, or the other advantage, if you want, of better documentation and using digital analytics is that this unlocks the potential for identifying various pain phenotype to better manage pain. So how can we do this potentially with PainChek? So first of all, as I mentioned before, PainChek has the pain score, which means it identifies the presence or not and pain intensity. But also, as you can see from the slides, you have the 6 domains, each of which has their own indicators of pain. So not only that you're getting a pain score, pain presence, but you're also getting other indicators of pain when you go and basically look into the assessment. So basically, you are also, if this person here has a pain score of 15, which is moderate in pain scale, but you also know that they're verbally abusive, they're aggressive, and they also know that they have an altered sleep cycle or prolonged resting, or you might have other indicators as well. So you can still have a moderate pain, but without them being aggressive or verbally abusive, without having a sleep issues as well. So basically, through other components of PainChek, you can see that you can basically get the impact of pain or how the person is experiencing pain. And this is very important because we wouldn't treat someone with moderate pain who's aggressive in comparison to someone else with moderate pain who's not aggressive. Clinically, we would not treat that person the same. So basically, this system, which is the PainChek score, together with other indicators of pain from various domains, that equals pain experience. And then that can basically open the doors and can allow users, carers, clinicians, they can allow a personalized pain management. So this is I believe what's really important when it comes to data analytics and using the portal itself. And then, as I said, it's the third component, which is the education component, which we believe it empowers users because we basically train every user of PainChek on challenges of pain assessment, on triggers of pain, and on the use of the system as well. And we know from existing studies and various data that this is a much needed space, as you can see here from these various studies. So far, PainChek has trained a lot of PainChek users. This is a slide that only compares various users that have been trained or educated from March 2021 until December 2022. So there's thousands and thousands of PainChek users that have been trained, and this we believe has an impact on the overall pain assessment. What we also currently involved with at PainChek quite a lot is to continuously build evidence on how to basically improve pain or clinical outcomes in general. Because the system that I show you, we have this iceberg approach. It uses the AI, it's got the smart automation, and it has the point of care capability and all that. But there's these potential other issues which sit underneath the iceberg that basically have a role in how you then clinically manage the patient. So starting from improving diagnosis, which can lead to potentially improved behavioral symptoms, to reduction in use of antipsychotics, to improvement on how you use analgesics and what analgesics potentially you use. Whether that can lead to reduction on safeguarding as well, because if you're having pain and which is untreated and pain is causing these behavioral symptoms that are then causing safeguarding incidents, well, then logically, if you tackle pain, if you manage pain properly, then you would have a reduction in safeguarding events, improved mobility, reduction of falls, and so on. So these are all these issues that can be potentially addressed. So we're focused on building evidence on how to actually prove these, because by dealing with pain better and more efficiently, you can potentially address these issues. And it's not just the clinical outcomes, there's also administrative specific outcomes as well that would sit underneath this iceberg. Provision of training, for example, has administrative implications in terms of empowering the user. There's administrative implications when you solve documentation issues in terms of saving time, in terms of recall of how you enter the results. Often when carers use another point of care assessment tool, such as Abbey Pain Scale, and especially if it's manual, then sometimes the results are entered in the care system that you use a couple of hours later because you're just too busy in terms of the workflow. And when you enter the results in the system a couple of hours later, that creates bias issues. So there's an administrative burden that you solve. Improving communication also has clinical implications, because when you do a PainChek assessment, that goes directly from the app, the point of care app, to the portal, and users also have access to the same patient. So within the care home, the clinicians have access to that. So the communication on how they're going with pain is also improved. Recently, I had a discussion with a US doctor, and how could they potentially clinically find this useful in terms of the portal. And it was a very good example how you see that a pain category was identified in a person. For example, a person had severe pain, but according to all the guidelines, after you identify pain, you need to reassess pain, and you need to reassess pain 1 hour after the actual intervention, because you need to do something about someone being in pain. But when you chronologically view the results as a clinician, as a manager of the care home, etc., you can see whether the person has had that intervention, and more importantly, whether pain intervention has worked or not. Because after the first assessment, when the severe pain was identified, and if you do a reassessment after 1 or 2 hours, assuming that an intervention was done, then if the intervention was successful, you should see a reduction in pain levels, and therefore you can basically see whether the interventions that you are applying in your care home, either pharmacological or non-pharmacological interventions, you can see whether they're working or not. This is a critical component of data analytics, and it's a really good example of how that could potentially help with management of someone's pain. And empowering staff is always a focus for us. I mean, if you train someone more in terms of how to recognize pain, when to assess pain, how to recognize triggers of pain, believe that also empowers that person as well, which is very significant. As you know, PainChek is currently in the UK. It has been used now for a while. There's a number of facilities that use PainChek, and we are already starting to see these benefits that we assumed they would come up, which are currently sitting in that slide under the iceberg, but that they would come up. One example is, for example, with our clients at Orchard Care. They've used PainChek as a part of psychosocial wider intervention. So not just PainChek alone, but as a part of a psychosocial intervention called the Reconnect intervention. And what they've seen was quite interesting, because it's exactly those points that I mentioned underneath the iceberg. So basically they're evidencing, and this is continuing, they're evidencing reduction in use of antipsychotics. They witnessing a reduction in use of benzodiazepines as well, which is another notorious group of medications. Coming from a pharmacy background, we know the implications of using those medications. What was really interesting for us was that they've also seen a reduction in safeguarding events. So during that period of time, since they applied this multifaceted intervention, which also included PainChek, they've seen an over 90% reduction in safeguarding reported incidents due to distress. So that's quite significant for us. And there's other studies. We have this PainChek Scottish phase 1 pilot, and they are witnessing a reduction in falls. In the first 12 weeks, they've witnessed quite a lot, but then that stabilized because that might have been due to other issues as well. But the overall reduction in a 24-week period of time was about 42%, which is, again, a really, really significant. Similarly to Orchard Care, they're witnessing a reduction in distress and so on. So you're having these clinical outcome implications that are being improved as a result of using PainChek, either as part of a multifaceted intervention or as merely as part of simply addressing pain better. So these are all significant clinical outcomes. Now, in Australia, PainChek has been used, as I mentioned, since 2007. There's a lot of care homes in Australia that use this. And as a part of a national-wide rollout of PainChek, there was an evaluation by KPMG. And they found also interesting results. So when it comes to aged care workforce, they've noticed the increase in capability and confidence to assess pain, which is really beneficial, and it goes in line with what I was mentioning in the when I was explaining the iceberg slide. These were all sitting underneath the iceberg, but they're coming up now. They've also identified improved pain management practices across these care homes. The data sharing has improved as well, which also has significant implications when it comes to communication, when it comes to multidisciplinary teamwork, and overall the quality and safety of aged care has improved according to this report as well. So these are all implications, clinical outcome implications as that have been identified, that are being reported. We are still building evidence. There's more studies underway that are being conducted with PainChek. But as I mentioned before, these would all be continuing evidence to support the benefits that I mentioned underneath the iceberg. So they've told me I've got about 40 minutes, so I think we are at 40-minute mark. So I will stop there and leave if there's any questions for me, if I can answer any of those. And you can contact Tan or myself. Tan is UK PainChek head for UK. So any further questions, etc., especially related to clients and especially related to UK, you can contact Tan.
Thank you, Kreshnik. There's been some really good questions coming in while you've been talking, which I've been monitoring. So thank you very much. That's a really interesting presentation. I have to say, I'll say my little bit first. I've got a few questions of my own, but I'll save those if we've got time at the end. But I was really interested in all the different ways that you're looking at the clinical outcomes. And one of my thoughts was, and I know you're talking to QCS Quality Compliance Systems, and they're, I work as their dementia care champion, and they actually acquired my PAL instrument, which is a cognitive and functional assessment tool. And I could see relationship of building that in for you to help monitor cognition and function as well. It'll be interesting. But anyway, so on to some of the questions. So a very simple one to begin with. Somebody's just asked, will they actually be able to get hold of the PowerPoint presentation? I know we're going to be sharing out afterwards the recording of this webinar, but I think they wanted the actual presentation to be able to show it to stakeholders.
Yes, I think Drew can arrange that with you, so I'll be happy to share the presentation.
Okay,
I can confirm that will be circulated afterwards.
Yes.
Fantastic, thank you. So that's a nice, easy one to begin with. So we've had a question about reliability and validity studies of the tool, particularly I would imagine of the assessment and the data. And particularly the questioner, it was Wendy, was asking about reliability and validity for use in acute hospital settings, and making the point that one of the issues is that the Abbey pain scale isn't specifically tested in that setting. What about PainChek?
PainChek has not been tested in acute hospital setting yet, but PainChek is being piloted in hospital settings as well. So I'm sure there will soon be data coming from that setting as well. So far, PainChek's focus, especially in Australia, but also in the UK, has been aged care. So this was the first point of entry for PainChek, but now PainChek is also moving into a hospital space as well. Recently, PainChek has partnered with InterSystems, which is a large provider of various solutions for hospitals. So, and it's being piloted, trial in hospitals, especially in Australia. So soon we will get some data around that as well. When it comes to validity and reliability, though, PainChek has been tested in Australia, and it has been compared with Abbey pain scale. So, and which then confirmed the validity and reliability of PainChek. It has also been tested. We had a trial in the UK just to test PainChek in the UK setting. It was part of a PhD project with one of the UK universities, and it has been validated in that setting as well. So there's a number of studies that have data on this. If you go to PainChek website under the clinical studies section, then there will be a whole list of various studies that have been used to validate PainChek as a tool. So this is how you check or you validate the psychometric properties, the reliability, the inter-rater differences, and so on. Now we are also getting, because now various researchers around the world are starting to use PainChek in their studies as well, and we're starting to see PainChek use from others and in various clinical contexts. I mentioned the study before conducted in Australia, which they've used PainChek when they were assessing neuropsychiatric symptoms in people living with dementia. So a list of all these studies so far that can all be accessed in PainChek's website.
Thank you. I hope that's helpful to everybody who was asking about that. And there's been a more of a sort of a techie question, if you like, about the data. Does it integrate with other systems such as electronic care plans and records?
Yes. So one of the yes, thank you. Yes, that one of the key advantages of PainChek as a system, as a solution, is the fact that it has what is called in technical context an open API. So an open API allows a software such a system to integrate with any other systems, and PainChek so far has been integrated with a number of, a lot of different systems that are used by various care providers. So the answer is yes. So
that's fantastic, because that is such a difficulty otherwise, isn't it? Because so many people, different organisations have different systems. There's, even within our NHS, there's several
Exactly.
systems.
No,
Yeah.
that is a massive issue. So we made sure, even in the initial stages of rollout and when PainChek was conceptualized, we made sure that this is software, this is a solution that can easily and freely integrate with any system. And then the specifics of how you integrate, whether you want to create additional features and so on, that's up to providers. For example, we have providers that have integrated PainChek and that have designed or customized together with PainChek alert systems. For example, if someone has a severe pain identified, then the system would alert the care staff to do a reassessment after a certain time period. This is just to help with good clinical practice and to help with really making sure that a person is not being unattended, or a person is not basically silently suffering from pain. Because people with dementia, I think this is a big issue, and it was our big motivation when we started PainChek, making sure that people with dementia do not silently suffer in pain. So and those specifics are part of the system and part of the customization of that particular integration.
Thank you. And I'm just, we've got a couple of questions actually that are sort of related. So the first one was asking about the way that the facial AI is used. Is it a photograph, or is it filming somebody? And presumably there's a link with Mental Capacity Act, taking a mental capacity assessment for people, giving permission for that.
So that is a really good question. That's a really good question. First of all, PainChek is GDPR compliant in terms of data, in terms of the solution itself. And but PainChek does not capture a picture of a person that is being assessed. It does not film the person. It does not record the person's face when it assesses for microfacial features of pain. PainChek simply scans through the face, and it looks for microfacial features that are called action unit codes. Now, action unit codes, there's a number of the human face is pretty much mapped. There's a catalog of action unit codes, and 9 of them that we've identified in the initial stages of PainChek, 9 of them are more specific to pain. So PainChek, the AI system, scans through the face, does not record, does not capture a picture, and it scans in order to identify those particular AU codes, and then it produces a score from the face. PainChek does not identify the person. So although it is scanning the face, it's not going to tell you whether this is Mrs. Smith or Mr. John. That PainChek does not do that. So it does not identify the person. So that has obviously, as you can imagine, implications in terms of privacy and so on.
Thank you. And sort of kind of related to that, this is my question actually. It made me think when I saw the other domains, which I was pleased to see, is that lovely holistic approach then. And I was wondering about people with conditions such as Parkinson's related dementia, or dementia with Lewy body disease related, where they might well have muscular impact on their faces, and so have what we call that mask-like expression.
Yeah,
so
muscular facial spasm that you...
Yeah, so presumably the AI wouldn't work so well for reading the face. So is it possible to use PainChek without using the facial element and use all the other domains?
Short answer is yes, but we haven't tested PainChek in people with Parkinson's. Okay, we haven't tested, our formal studies have not used that. But as you mentioned, if that depends from how much face is affected by the condition. So you have patients with Parkinson's that are not affected or that are partially affected in terms of face. In those patients, you may have difficulties in terms of accurately assessing with AI. Although we have some preliminary studies done in the UK, actually, they reported to us that they have successfully used PainChek in patients with Parkinson's, but we cannot, because that study is not out and because it hasn't been formally tested and validated, that is not an indication. So,
so you feel another research study? That.
But there will be such study, I can imagine, because we constantly get various queries from researchers to use PainChek in different contexts. But you also have to bear in mind that PainChek as a system, as a tool, is quite robust. So 9 indicators out of 42 indicators are face, which then means you can also continue to assess other non-facial aspects of pain. And if a person is in pain, I mean, you can also identify other components and come up with a score. But the short answer is that in Parkinson's, it hasn't been formally tested.
Okay, thank you. And is that just to clarify, is that the same also with Lewy body disease as well?
Yes. Now, in various studies that have been conducted, there were people that had Lewy body dementia. That depends on whether face is affected or not. So if the face is affected, then you need to basically use PainChek with caution. But you have to bear in mind that there are also situations that you cannot use facial AI component at all. In cases, for example, when it's too dark, or if it's not safe for you to do so because the patient is really aggressive, you cannot approach and so on. There's always the option of using the manual option of face assessment. So we also in our training train users how to assess face without the AI.
Okay, thank you.
So,
and
just
on
to make
that,
sure we cover the bases.
Thank you. And on that, actually, Anna's just wanted just to further clarify, and I think I know the answer to this, but I'll let you tell it, it's yours. She's saying, just to clarify, you're not the caregivers who are completing the assessment don't tick the boxes, do they? They use a mobile device, I'm assuming, to actually scan the person's face.
Yes, they use a mobile device to scan a person's face, and then they move on to other domains such as vocalization, behaviors, and so on. In those other domains, then they have to click on the features that are that exist or not. So they have to use that manually. So, but they go through a digital checklist, and it's a digital checklist that is assisted by a number of features that we've introduced, such as I mentioned before, the information component. So each feature, such as groaning, moaning, being aggressive, and so on, has an I button, so you can click if you're not sure what that means. We believe that further improves the accuracy of the tool because it helps, it guides carers regardless of their level of education, level of knowledge about the actual particular feature. It helps them to identify that or not. But it is a digital checklist. They need to click on it to indicate presence or not.
Thank you. So I can see Valeria's got her hand up. We'll come to you in a minute, Valeria. I saw that you'd asked a question. I see you, I think you're in Canada and have a care home, want to know about getting started and the cost, which might mean there's something else to either you or Drew, I don't know. But just before we do, Wendy asked about, is there a minimum age? Is there an age specific element to the validity?
No, there's no. This is for PainChek. PainChek is for adults, basically. Adult population group is not for kids.
Okay.
PainChek has another other project and other solution that is focused on infants that cannot communicate, but that's different.
What's the minimum age then? Is that, are we talking 16 or younger?
It would be 16 plus, you know, with a person unable to communicate. We haven't really tested in those population groups, but this is PainChek is for adult population groups.
Okay,
So
thank
it's
you.
for that age group. It is tested against the and compared against the Abbey pain scale. So it's not limited to dementia only. There are other conditions that might render a person not able to communicate. So you can use in other potential conditions that render the person unable to communicate. That you might have a palliative care situation where the person is unable to communicate, and you can use PainChek as well, just like you would use Abbey pain scale. When it comes to the question around Canada, PainChek has just recently started in Canada, so it's in the initial stages of rollout. But she can email PainChek, and I'm sure they'll give her more information specifically about Canada and how the rollout and how subscription or all of that is going there.
Thank you. And I imagine if anybody's interested, which I'm sure they are, that if they go to your website as well, it'll say about the costs there, will it?
I'm not actually sure. Drew might know this better than me, but certainly if you contact PainChek in the website, contact@painchek.com, then you'll get a prompt response and elaboration of that.
Thank you.
I'm just going to pop my email address in the chat, so anyone that wants more information on pricing or just wants to learn a bit more about how PainChek could be used in their organization, they can reach out directly to myself.
Yeah.
That's excellent. I'm just having a quick look at all the chats. I think we've actually answered everything that was on the chat. I'm very sorry if you heard a little noise off. It was my cat who's become deaf, so he shouts a lot. So there was a bit of a background noise while it came meowing through, so sorry about that. Valeria, I see you still got your hand up. Did you have another question, or was it just that you've not had a chance to take that down yet? I'm not sure.
No, I wanted to say, as a clinician, I'm a clinical educator in Canada, working in a major hospital. And I was always wondering, and I was always affiliated with Sentinel events associated with people not adequately assessed for pain. And I'm so grateful to have heard of this. I stumbled upon it by accident as I was looking for some kind of software to solve this problem, but particularly in palliative patients. Now, I'm really interested in initiating this technology. I think it's super important. And I just want to commend you for your efforts. I'm very passionate and I'm excited about your company and this whole rollout. And I really want to get it in Canada already, because I think it would really benefit our patients. So I will reach out to Drew, and thank you so much for your presentation.
Not a problem. So PainChek is already in Canada, and I'm sure they'll be able to help you with that.
So thank you. Yes, and I could hear the excitement in Valeria's voice, and I think that's probably reflected in a lot of us as well, me most certainly. So I think we've come to the end of our time. Has anybody got any further question? Oh, I can see another chat has just appeared. Oh, that's somebody else thanking you for an excellent presentation.
And my apologies for the connection issue. I don't know what happened.
I think we're all very forgiving about things like that these days.
Hopefully I didn't click the wrong button, but anyway.
Okay, well, thank you everybody. I hope that was useful to you, and do visit the website if you want to find out more as well, or email.
Yes, please reach us out for any question or anything. Thank you.
Okay, everybody, bye bye.